I think we're going to get started here, but obviously people will just filter in as they're ready. But I want everyone to have a chance to ask their questions and really participate. Thanks for being here all day. So I'm the moderator, Tammy Smith. I'm a neurologist. I see patients primarily at the VA. I'm going to pass the mic and let the rest of the panel introduce themselves to you.
Hi, everybody. Thank you for being here. My name is Hina Garg, and I'm a physical therapist. I've done my master's and PhD, and I have different associations through Rocky Mountain University Health Clinics. There's the MS Physical Therapy and Wellness Center, where we see a lot of folks with MS and NMO, plus a few other chronic inflammatory conditions, which are like CIDP, et cetera. So we have a neuroinflammatory base a little bit there. It's been going on for several years. And then we have free wellness that we provide so that people can continue down this path and journey, and a lot of education that they're able to receive. And I'm also, through the University of Utah, associated with the neuroimmunology department as an adjunct.
Good afternoon, everyone. I'm Sara Lenherr. I am a urologist, so I take care of all of the plumbing. I am fellowship trained in complex voiding dysfunction and neurourology. So my job is here to help you manage your bladder symptoms and make sure that your bladder doesn't run your life. And I'm at the University of Utah.
Melissa, be really careful. You're near the edge.
Yeah.
Hi, everybody. My name is Julia Klein. I'm a nurse practitioner at the university. I've worked in the neurology clinic since 1996, and so I've been around for a really long time, and I've seen a whole lot of different faces of what we're treating and what's going on. And I am affiliated with the division of neuroimmunology, and so I'm pretty much always around. So when people are having specific difficulties or problems, a lot of times you'll be plopped in to see me, even though I'm not your affiliated doctor, to help kind of sort through some of the immediate troubles going on.
Hi, everybody. My name is Olga Neal. I'm one of the child psychiatrists here at the University of Utah. I did my general psychiatry training as well as my child psychiatry fellowship training here. And now I currently work for the Neurobehavioral Home Program, where we specifically take care of people with autism and developmental disabilities and provide psychiatric care. But I'm kind of here today as general psychiatry.
Hi, I'm Brad Katz. I'm a neuro-ophthalmologist across the street at the John Moran Eye Center. And so neuro-ophthalmologists deal with eye and vision problems that have resulted from brain or neurologic problems. And so I see a lot of patients with many of the conditions that some of you might have, or some of your family members might have. And so I'm really happy to answer any questions you might have about your eyes or your vision.
And I'm Melissa Cortez. I direct the autonomic lab here. We opened about 10 years ago or so, and I see a combination of autoimmune autonomic disorders and then complications of other autoimmune diseases that affect the autonomic nervous system. So we do that in a diagnostic and a clinical sense.
All right, thanks everybody for those introductions. So this session is really about managing symptoms and comorbidities. And this came up in another session earlier where I can't remember the exact question, but I really mentioned that a lot of our neurologists are really focused on preventing attacks and relapses, and it's easy to overlook all of the other symptoms that come along with having a chronic autoimmune neurologic disease. And so this is just really your opportunity to chat with these folks about the symptoms that you or your family members have experienced and try to get some guidance and ideas on how to handle those. So maybe we'll start with Dr. Garg here to talk to us a little bit about some of the specific things within physical therapy that she does to address symptoms in our patient population.
So I'll give you a general overview, and of course everybody's symptoms are so different, and please feel free to ask questions towards the end, how this may apply to you. Generally what I see is some individuals, if they're early in their condition, are reporting a lot of fatigue and a lot of pain or more like not being able to keep up with things in terms of activity, or they exercise, but then they're so tired for like the rest of the week. And those are the things that's kind of the spectrum that's early in the disorder. And I tend to give them a baseline examination about what their muscle strengths are. And actually that's a very good thing, because I feel sometimes I can exactly direct them. These are the muscles that are weak right now, and you need to make sure that you strengthen them, or these are the muscles that are tight right now. As you progress through your condition, as you manage your condition, this will become important, in 5 years, in 10 years. So it has been very good that way. For symptoms which are sometimes hidden, like this fatigue and the exertion intolerance, then I give them specific strategies for how to manage that fatigue, where is that coming from, and if there is something in terms of physical fitness that they can modify, or how can they keep up with their fitness without getting so intolerant to fitness and exercise regimes, right? So like, how do you manage exercising and keeping up with the energy throughout the day and throughout the week, and not be crashing every single time? Like, that's the kind of education. Also, energy pacing, energy management and activity pacing is something that we talk about a lot. So I know it seems sometimes to people that I can't do everything, but my goal is you can do everything. How can we modify or build a reserve to get you there? Right? Like, that's the idea early on. Later on, I get to see people for different kinds of issues, like in coordination, balance, falls, and mobility needs, weakness. So I put them through all of these regimes to train them as best as I can and make them functional through their journey. Yeah. Oh, sorry.
Thank you. All right, and now I'll ask Dr. Lenherr to tell us a little bit about what she works with. Specifically, like, a lot of patients come to us and don't even realize that there are urologists, there are doctors who specialize in symptoms to help either strengthen the pelvic floor or help with voiding. Obviously, people with spinal cord issues can have a lot of different areas of dysfunction, and so I really think it's so great to have you here, and I'm grateful we can refer patients to you.
Thank you so much. So the fundamental thing that I think about as a urologist is that the bladder's job is to store urine until it is socially acceptable for us to go to the bathroom. And hopefully when you go to the bathroom, it doesn't take that long, you're not stuck there taking an hour, and you haven't leaked in between those voiding episodes. So that's the normal job of the urinary system. And when we have neurologic problems, our bladder just doesn't really know how to store and or empty. And so a lot of the patients that I see come in complaining, reporting urinary frequency and urgency, or sometimes they get to the bathroom and they feel like they need to go, but they can't get the pee to come out. And so that's where I really work with you on what sort of symptoms are bothering you and what is the impact of that bother. And also there's some safety issues that we can consider, whether or not it impacts your kidney function or your infections that can cause a lot of issues with safety. If you're getting admitted for urinary tract infections and sepsis, that's a big issue. So we have quality of life and safety. And for the quality of life side, sometimes I have patients that say, I'm okay if I just go to the bathroom 10 times a day and not 30 times a day. You know, we really have to meet your quality of life and try to do what we can to keep you safe and meet some improvement. We don't have a magic bullet to fix all of these types of urinary symptoms, but I definitely work with you on all of these storage issues and then the emptying issues. And everyone presents with a very different type of situation, but all of these symptoms can be addressed in some way and not just pass it off as something that you have to put up with, or you're getting older and therefore you have these problems, or you had babies, or you have a bigger prostate. All of these things are things that we should talk about to see if there's anything that we can do to help.
Yeah, that's so important to remember, right? That we don't just have to deal with what is, right? There are options. All right. Next, I'm going to ask Julia to just chat with you all a little bit about some of the most common symptoms that maybe the neurologist, that the primary doctor looking at relapses is not addressing, but then patients come to you and they say, this symptom is really driving me crazy, and my doctor just hasn't really addressed it.
Can you hear me? Okay. So anybody could shoot questions at me as well, which would be great, because then I don't have to just make up something. But I would say commonly fatigue is huge as an issue. I think within that is also kind of comes in mood issues and mood problems, like I feel so worthless, I can't do what I want to do. I just don't have any energy. I look normal, so people think I'm faking. All of those sort of body image disorder kind of issues with fatigue. Spasticity, I think, plays into fatigue. It takes a lot of energy to fight through really tight, disorganized muscles when you're trying to move. And pain. Pain's huge. Pain wears you out and can be a chronic, ongoing thing. All the medications we tend to dump on patients to try to address these issues kind of compound other issues. So most often, a lot of the drugs we use to help treat symptoms, as opposed to use different modalities like physical therapy to address spasticity or to help with fatigue, are fatiguing. And so it's sort of like you're stabbing yourself in the foot trying to treat a symptom. And I hope I covered or answered your question.
That was great. Yeah. All right, Dr. Lane, thank you for being here representing all of psychiatry for us.
Anytime.
So, what are some things that you see in patients with chronic medical conditions from the psychiatric standpoint, and what do you think is a good approach for patients and their advocates to take?
Yeah, I think that the biggest thing is something that's already been talked about a few times already, which is fatigue. We get people all the time that come to see me. When there's a lot of fatigue, we really look at how they're sleeping, because sleep is so important. And if you aren't sleeping well, it's hard to heal, it's hard to function, it's hard to engage in physical therapy, it's hard to do all the things you want to do. And so the biggest thing that I actually look at first is sleep. Sleep also really impacts your mood, as does having any kind of neuroinflammation in the brain. It impacts, psychiatry and neurology, we kind of treat the brain. We both treat the brain, it's the same organ. And we know that neuroinflammatory conditions increase the risk of things like depression and anxiety and PTSD, which are the three biggest things that I'm screening for in terms of psychiatric conditions that we can treat. With rates being pretty high, especially in somebody who has, say, been in the ICU. Rates are pretty high of those things. So that's always in the back of my mind. But also, if somebody is just in my office and I'm talking to them, I'm thinking, okay, is this fatigue due to depression? Is this fatigue due to anxiety? Is this fatigue due to just a neurological symptom? Is it a side effect of a medication? And how can I help with that? I also look at pain. I look at one of the big things that I talk about with people is that this is often a really big life change for them and for their family. It can involve loss of a job, loss of health insurance, changing identities, changing what you like to do. Can you still do your hobbies? That type of thing. And so kind of brainstorming how to help people feel good again, feel happy, feel fulfilled, feel like they're able to engage in the things that they want to engage in. Sometimes I use medicine, sometimes I refer to therapy, often I refer to therapy, and just really kind of try and figure out how I can support people and their families.
Great. Thank you. All right, Dr. Katz, you're up.
My
stuff.
Sure. My job is trying to help you do, be all you can be, with the vision you've got, with the eye movements that you've got, whether it's glasses or eye drops or things that magnify your print or devices that telescopes that allow you to keep driving. We've got all kinds of gadgets, gizmos, tricks to help you use the vision that you've got. And also we want to preserve the vision that you got and make sure you don't get some other horrible eye problem that's unrelated to your autoimmune neurologic problem that's going to make your vision even worse. So that's kind of my job.
Thanks. All right, Dr. Cortez, the autonomic nervous system that most neurologists even have trouble understanding. So what symptoms do you see often in our patients with neuroinflammatory diseases that you can help address and that they can know to bring to their providers and advocate for themselves?
I mean, briefly, what the heck is the autonomic nervous system, right? So it's the part of our nervous system that does what is automatic for us. So the things that we don't have to think about. So it helps a little bit with the urine storage and release that Dr. Lenherr talked about. Helps with our sweating, our pupil function, our breathing, our heart rate control, our blood pressure control. And so with autoimmune and autoinflammatory conditions, there is an interaction between the immune system and the autonomic nervous system. Our autonomic nervous system is trying to keep us in balance in whatever environment we go into. So if I go outside and it's hot, it's going to allow me to adjust to that temperature change. Or I stand up, it's going to allow my blood pressure to adjust to my standing up. And if your autonomic nervous system is reacting to either a systemic inflammatory condition or an inflammatory state that's active and ongoing, then that autonomic function is actually disrupted. So we see a lot of what we would refer to as secondary autonomic disruptions from the active, untreated inflammatory or autoimmune disease. And then sometimes we see consequences of injury of the autonomic nervous system. And that usually looks like blood pressure control problems, too low of blood pressure usually, erratic heart rate patterns. And this theme that's come up a lot with fatigue can be a symptom of erratic blood pressure and heart rate control. So sometimes what we're working on is trying to measure that dysfunction and name it so that we can direct treatment around normalizing those things, because it's swinging both ways. It can be too high or too low. You have to figure out which way before you try to fix it. And so that's an area we focus on most. There's not as many tricks and tips for the temperature regulation part. It's too cold, it's too hot, my body can't keep up, but we do have some tricks there. And then some physical therapy sort of overlapping in the territory of some of the fatigue mitigation, cardiovascular training can be beneficial too. And so we work closely with our rehab colleagues to use exercise and physical therapy to address some of the autonomic problems.
Thank you for that overview, everyone. And yeah, one really important point here that I think has come up is that we're always trying to help treat the symptoms. So we're trying to prevent relapses, trying to prevent flares, but then we also want to help treat your symptoms, but it's a balance and it is personal for every single patient. So where is the side effect from the pain medication acceptable if it's contributing to fatigue or brain fog from certain medications? It's a constant balance, and I wish we could just do a blood test and know that this is the combination of medications we need to give you to let you live the life you want. But it is a lot of trial and error and partnership with all of these different providers. So, all right, I want to turn this over to the audience. We're really here for you guys today, so I'll walk around with the mic and hand it over for anyone who has questions.
Thank you. Can you hear me? Hi, my name is Michelle Hill, and I have questions for a couple doctors. First of all, Dr. Garg, I fall a lot. I have stiff person syndrome, and I fall a lot. I'm full of bruises. We found several more this morning. Because of it, I have gluteal tendinopathy, and so I was referred to a physical therapist. In his office, I went into severe SPS spasms to the point of 45 minutes just screaming. They probably thought he was torturing me. And I asked him specifically, does the University of Utah have any physical therapists that specialize in muscular diseases like stiff person syndrome? And he said no. And you're sounding like you say yes.
Well, so the answer that you're asking definitely is no, I think. Like, you want to go to a neuroclinical specialist who is board certified. That's the first thing that I would say if you're trying to find a physical therapist. you want to go to that specialty. So I am a neuro board certified specialist with specific fellowship and training with MS and NMO, like type of training, right? So I think, I don't know if at the University of Utah somebody else like that is there, first of all, but the thing is, like, I am an adjunct here, so there's ways that you can kind of get in touch with me. It's not that you can't. Maybe that's what happened in that situation. You went to an orthopedic physical therapist, and they, although I love my orthopedic colleagues, I just think it's like urology. You would want to go to a urologist, for your bladder issues, and maybe not immediately to Dr. Cortez for autonomic issues. Like, that's the same situation in the field of physical therapy and rehabilitation. We have different avenues for specialties, and you want to go to a neurological board certified specialist who has some form of background and training. And I would love to talk to you later, just to kind of figure it out. But I can see why it triggered the spasms. But I think they didn't have the background to help you. I'm really sorry about that. Yeah.
Okay.
But I do know, I'll just make sure that I specify this. I do know that there's a neurology, outpatient neurology center. Like the Craig Nielsen has a neurology clinic. So that would be my best referral source for you if you really want to stay close and figure somebody out. That would be the outpatient neurology over there. Yes. Yeah, the Sugar House. I thought that moved to. So that's the one that I'm talking about. Yeah, and I'm happy to give you the information for them. Yes.
My physical therapy for my neurosarcoidosis happened at NeuroWorks out in Sandy. And so your doctor has to refer you there. They won't just take you off the street. So try that. They were so helpful to get me walking again, my balance issues, things like that. So I know our diagnoses are completely different, but they really helped. Yeah.
Yeah, and I concur. Like anybody that has that neuro background, NeuroWorks is another very good outpatient, not associated through University of Utah, but definitely a good outpatient neurology rehab setting. I really hope that you can find somebody.
Okay. So I have a comment for Dr. Bradley. I live in New Mexico, and I've heard that there is a neuro-opt in New Mexico. I've never met him, but I'm hoping to meet him this weekend at Night for Sight 2025 with the Juliet Eye Foundation. Have you ever heard of the Juliet Eye Foundation?
No, tell us about it.
So Dr. Robert Melendez, he's an ophthalmologist. He diagnosed me with optic neuritis back in 2007. They help patients that want to go to school. So they give them a scholarship. And he's really awesome. They're doing the award this weekend because they're awarding the scholarship to patients that have eye conditions. So I encourage people that do have an eye condition that are going to school to apply for this grant. Yeah, it's really, really awesome. So maybe Dr. Bradley, you could look into it. His name's Robert Melendez. Absolutely amazing ophthalmologist. They say there is a neuro-opt in New Mexico, but I've never met him. So I'm hoping to meet him this weekend. I also have a question for, I forgot your name, but you are for the autonomic nervous system. So I experienced like swelling on my legs, and I've been told that it's because my autonomic nervous system was affected. Is that one of the symptoms when you have like I guess a relapse or an attack because of NMOSD?
One of the tricks about autonomic nervous system is it's there to do all that regular stuff in the background. So the question is usually sometimes or maybe, but it's very plausible that you're having some, what we'd refer to as vascular insufficiency in your lower extremities that can increase swelling. That's actually really common, not just to those with NMO or it's actually I think, common across many medical conditions, including neurologic conditions. So the ways that we address it are not specific to the nervous system as much as the places that they're most bothersome. So if the swelling is in the lower limb, compression is often useful, and moving physical therapy strategies are often useful. Rarely would we want to try to throw a medication at something like swelling alone. And oftentimes it merits talking with your primary care doctor to make sure that it's not a heart problem or some other unrelated non-neurologic source. Again, because it's a sort of maybe question.
I know there is like treatments, like how you said, compression and stuff like that. But if your autonomic nervous system was affected, like how mine is, because I'm experiencing swelling, of course they've already checked all my heart conditions, all of that, make sure I'm cleared and they don't find anything. Will that ever go away, or will I have to always wear compression?
One of the things that's very satisfying to me in autonomic neurology is that people do see improvement. There's a sort of an ability to sort of retrain or train more advanced training beyond where you maybe used to be of your cardiovascular system to overcome some of the deficits of the nervous system. So some of that physical therapy approach is where my patients see the most benefit, where they're able to actually reverse some of the abnormalities or get them to at least improve and stay improved over time.
Okay, that makes a lot of sense, because I do go to physical therapy and I have seen improvements. I do compression and it does help. So, I mean, that brings me a lot of hope. Thank you.
Thank you. Got over there and then here. I come in. Sneak it past. Here you are, ma'am.
So I might be rewinding a little bit. It seems that there is a word that is connected to everything, which is inflammation. So is inflammation a comorbidity, or is it attached to inflammation of the eye or inflammation of the heart? Or you see what I'm saying? Are we studying inflammation, and how come I have so many unhappy, inflamed things?
Inflammation is what's happening with the disease. So when it's unchecked or untreated, it's in the attack mode, depending on what your particular disease is doing, whether you have an antibody problem or, and so that's why, everybody's busy piling on steroids and figuring out what base drug is going to keep that disease quiet and decrease the amount of inflammation. But then there's a subsequent damage that's happened because of the inflammation, and all of that damage is leaving folks with symptoms. So to what degree that inflamed tissue can heal, it remains to be seen. It's like, during the course of time, like somebody started out, they couldn't walk, but now they can walk. So where you are at your worst is often not where you will be at the end. Does that make sense?
I'm trying to, wrap it around my head and make sure that I understood your question. Let me give you an example. I have what's called lichen planus oral. So, which I'm glad about, don't look it up. Because there's other places it goes. The dermatologist tells me that that's the way my body is trying to expel inflammation through these blisters and sores on my lips. So that in itself doesn't, it doesn't help me understand that inflammation is not a disease itself. And then it's attacking or attaching to other things.
I mean, the diseases we're talking about today, pretty much all of them fall on this spectrum of neuroinflammatory disorders. A few are immunodeficiencies, but it's either hyperactive or underactive immune system function. So I would say that's the root, that's the morbidity, and then the comorbidities are the other symptoms that are expressed because of that, things like fatigue or pain or spasticity, things that sort of happen downstream because of that inflammation. But you're right, the root cause of everything here is something either inflammatory or an underactive immune system. Yeah, thanks.
Hi, everyone. I have a question. The registered dietitian in me, I'm curious. The anti-inflammatory diet, is it a legit thing? Of course, we want to avoid ultra-processed foods, refined carbs, alcohol, sugars, da-da-da. Any tips and tricks regarding inflammation and diet?
I can just tell you a little bit because I do talk to my people because of my wellness realm, a little bit about their diet, sleep, etc. And I've done enough reading. It's hard to pinpoint any specific diet is what I would think, and I'm sure like everybody can contribute here. However, there is enough evidence to try to avoid inflammatory foods where people have been able to, there's anecdotal evidence, a lot of anecdotal evidence, okay? So diet studies are very hard to do, but a lot of anecdotal evidence also where people have been able to manage their condition by following more plant-based or avoiding like red meat or type diets. So again, but like I'm coming from what I've seen sometimes has worked in my patients also, so yeah.
I'll just add from managing bladder symptoms, definitely avoiding things like bladder irritants can be beneficial. So there's you're specifically asking about the causality, but I can talk about the management of symptoms. So decreasing intake of coffee, tea, artificial sweeteners. Some people say bubbly things. Julia's saying, don't judge me because I have my Coke here. But if you notice that they impact your bladder and you have to go more urgently or frequently or have any associated pain in your bladder after drinking or eating these things, sometimes you can eliminate them and see if that helps your bladder symptoms. The other thing is not drinking too much fluid. However, I know that with autonomic dysfunction, sometimes you need to drink copious amounts to keep up with your blood pressure. So this is a balance. And then the other aspect that I tell people that's generally easy to think about is anything that might burn the inside of your mouth if you had a cut in there, like pineapple juice or tomato sauce or something like that. If it would maybe burn the inside of your mouth, maybe it might bother your bladder. So that's kind of an easy rule of thumb. If you feel like those things are associated, try to eliminate them, but don't drive yourself crazy restricting your diet if you feel like you like those things and they're not bothering your bladder.
Any other comments?
So I think it was already said about the sort of evidence basis, and I've spent a fair amount of time synthesizing the information available about auto-inflammatory diets. There's definitely a spectrum. There's the far end of commitment to the most restrictive diets. They can be so restrictive, either financially or food selection, or the region you're living culturally, that the potential caliber of benefit doesn't weigh that expense to the individual. So I always talk to people about, do select those anti-inflammatory features that work for you in your life. Pay attention to your body, like what was just talked about. If things inflame your system, whether it's a urinary symptom, a skin symptom, there's a lot of different ways that our foods can worsen symptoms. Fatigue, I have a lot of patients who tell me about certain foods making their fatigue worse. pay attention to your own body's signal. That's probably one of the best things we can do. And then lastly, one very common thing we do in clinics is we check vitamin D levels. Vitamin D is anti-inflammatory to this inflammatory conversation. And so promoting vitamin D, and you'll notice a lot of the anti-inflammatory diets have actually naturally chock full of foods that have vitamin D in them as part of the like a Mediterranean diet. And we've talked about plant forward and minimizing red meat and processed foods. Those are ways that are sort of promoting vitamin D in the diet too, actually, so that can be useful.
Hi, just kind of new to NMO, not having had a lot of symptoms, but recently I've started having cramps in my legs at night where my toes curl backwards and I kind of have to force my feet. It wakes me up. Is that something, in my mind, is like, does that mean that something more is coming, or is this just something that's new to me? Is that something other people experience?
It wakes me up too.
If you've never had it before, I would probably check in with your people. They probably would want to look at imaging, but
I did, and nothing came back normal. I mean,
Okay.
everything came back normal.
So then, the first thoughts are electrolyte. Do you have issues with like low vitamin D, need a little magnesium, your B vitamins up to snuff?
Okay, thank you.
Sure.
Hi, I had two more questions. One of them was for Dr. Lane. I know you said you do general psychology, and I have 4 autoimmune diseases, 4 rare incurable autoimmune diseases, and 3 of the doctors have wanted me to go to cognitive behavioral therapy. And I've looked it up and said, no, that's bunk. I'm not going to sit there and pretend I'm at an ocean and, go to my happy place. And they just found one for me that's a CBT for chronic diseases. Do you agree that that is a logical idea, and what is it?
So first of all, yes, I think that sounds great. One of the things with therapy in general, including with CBT of any type, is that actually the most important part, far more so than what type of therapy your therapist is doing with you, is how well you feel like you and that therapist connect. So regardless of like if they're doing CBT, DBT, other types of there's so many different types of therapy. What you really want to do is find a therapist that you feel like listens to you, hears you, and has the same goals as you. And that, at the end of the day, is going to be the most important part. CBT is one of our most studied therapies, and so we have a lot of really good data supporting it, and we have kind of broken it down and separated it out for lots of different things. There's like CBT for sleep, CBT for chronic diseases, CBT for lots of stuff. And so, yeah, I think definitely going to see that therapist and giving it a try, but make sure that you feel like you connect well with the therapist. That's the most important part. And if you don't, it's okay to try and find another one. Ask for a referral to a different therapist, because you really want to feel heard and listened to, and like you and your therapist align with your goals.
But what do they do? I mean, for chronic diseases?
So it depends a lot on what you want to work on with them and what's going on. So it can be lots of different stuff. It can be helping, like for example, I have a lot of patients with chronic diseases where it might be trying to help them gain more functionality, going back to their hobbies, going to work, going out with friends and family. It might look like coming up with a plan for how we do that, how we can. One of the big areas of therapy that I'm more interested in is both CBT and ACT therapy, which is another type, but they're all good, and most therapists use a mix of them. But essentially, it's like, this is where we are, this is where we want to be, and how do we get you there? Sometimes that looks like breaking down the small steps, figuring out how much we can do with the pain and energy we have, what brings you joy, and how can we help you get there?
Okay, thank you.
Yeah.
And then my,
Sorry, everyone, just real quick. This has to be the last question just to keep things running on time. So
Okay.
we're happy to answer things.
all right, Julia, you said that when people say you look normal, what do you say to people when they say, but you look normal? Or what should you say to somebody? Because I have so many people that say, oh, you look great today, and I'm at a 9 out of 10.
Yeah, I think you got to find that place within you that is the answer. Is it a walk away? Because you can't explain it, I don't think. And I think that is just part of that internal difficulty with having any sort of disease state that is pretty consuming, but it's not like you have your leg chopped off or, I mean, it's not like this physical manifestation. You do look normal, right? But inside, your body's at war. So I don't have that great answer. I could say a real smart alecky comeback, but part of our instructions were to keep it family. So I'm going to give you that.
My face froze up because I was so upset about something, and the guy goes, what, you can't take a joke? Your face can't even smile and take a joke? I said, my face is literally frozen in fear because of what you just said to me. And nobody could get that.
Yeah, and I'm not trying to take away from that answer and conversation. I just feel like that's why you need to find the right people in your community who can actually understand and relate. And I think sometimes that's, the diseases are so isolating. So really finding somebody who can understand and share and not come from that other perspective. You see what I'm saying? So I that's one reason, like, I've seen such growth in my the clients that I've seen with the wellness. Like, they have this bond and camaraderie, and sometimes I don't even have to be there. I don't even have to be involved. I'm just like looking at them, and they're also engaged and happy. So really finding the people is where you can safely express yourself would be the best way to go.
And I think that's a great thing to work on with a therapist, right? That's a great conversation to bring to a therapist and say, this is what I'm dealing with, and it's really challenging for me to figure out what to say in these situations, and I'd love for you to help me work through that. Like, that sounds like a great use of a therapist to me. Yeah. All right, Julia, one more. Okay. Okay. I just want to thank everyone for their participation. Really, we learned so much from all of you and your questions. But yeah, we're going to wrap up this session because I think we have just 2 or 3 more sessions, and then yeah, thank you.